practically demonstrating the basics of echocardiography. Now, I am honored to welcome Satish Govind sir. Dr. Satish Govind sir is the Chief of Non-Invasive Cardiology at Narayana Institute of Cardiac Sciences, NH Health City, Bangalore. Sir did his MBBS, DNB, Fellowship in Non-Invasive Cardiology, PhD at KTH and Karolinska Institute, Stockholm, Sweden. Sir has more than 3 decades of experience. Sir is presently President of Indian Academy of Echocardiography and immediate past Editor-in-Chief of Journal of IAE and CSI. Sir is also the Secretary of NH Medical Ethics Committee. Sir, we are now honored to welcome you to share your knowledge with us.
Namaskar to all of you. It's a real pleasure to be here every time I come here, and I thank Satish for inviting me here. So Dr. Srikanth has set the tone talking about the basics. So from here onwards, it'll be a lot of other topics, and I will focus upon a topic which is very, very common in India, and which you will be seeing irrespective of where you work, in which hospital, in whatever context. This is a disease which you'll always see in huge numbers. So it is a simple sort of findings compared to congenital, but it is something which you should be aware. So I'll be sort of taking you through some of the basics and then to what you should look into more in a more detailed manner. Now, the term ischemic heart disease and you have this other term called as coronary heart disease. Preferably, it is coronary artery disease because ischemic is more, if you take the entire heart, the ischemia can even be microvascular. So preferable term that is being used now is the coronary artery disease. Now, a brief look at the coronary arteries themselves. So you have to have this mental picture of how the coronary arteries come out from the aortic root and how they go. And this is very important. You have to look at the picture in your books or wherever you see it, and you have to have some sort of a mental image and how it looks. And you have to interpose that onto the patient, and that's how you're going to look at it. You have these three main arteries, and you can see that you have the left and the right coming on this side. The left, the short course of the left main is there, and then you have the left anterior descending, which gives rise to the perforators and the diagonal branches here. And this is the one which is the most important, and it covers a wide area of the myocardium, and which you should be focusing, especially when you have a anterior MI. The other important vessel is branching of the left coronary artery is the circumflex. So it has got a small area. So these are the marginal branches. And as you can see here, this covers the lateral side of the myocardium, the LV wall itself. And then you have the RCA, which comes from the right side and goes all the way down and supplies the inferior part of the septum and the inferior wall also. So this is how you can look at in a very global sort of way. And this is a picture which you should imprint on your mind very deeply. Now, the terms. Regional wall motion abnormality. It's a very common term. So different institutions, different people might use it in a different way. So some will term it as RWMA. Some will say wall motion abnormality, WMA. Some will say it is segmental abnormalities. It's one and the same. And moment you write in your report that it is RWMA, you're implying to the person, the clinician, that there is coronary artery disease. So it's very important that you have to understand. So if it is coronary artery disease and if it is RWMA, they're synonymous with each other. But also keep in mind, a small percentage of patients will have RWMA due to other causes. So this you will come across once in a while, and you should be aware. So not all RWMA is going to be coronary disease. So you have examples of myocarditis, you can have Takotsubo, you can have infiltrative cardiomyopathy, LBBB. These can cause wall motions in a different context, and there are many other diseases also. And when you use the word global hypokinesia, generally the understanding is it means that there is no coronary heart disease. Though when we talk about triple vessel disease, multi-vessel disease, you see all segments which are going to be having wall motion abnormality. You might term it as global ischemia or global hypokinesia. So you'll have to be careful about it. But generally, when you use the term global hypokinesia, it implies that there is no coronary heart disease, and RWMA means coronary heart disease. And you also have to remember that in a small percentage of patients, you can have RWMA due to other causes, not coronary artery disease related. Now, let us look at the views. So this is something which especially the third years will be very familiar with. So we start with the parasol long axis. There are three main parts to it. So one is the walls. So this is very, very specific. As you can see that where the that orange line cuts. So it cuts, the septum is divided into two parts, the one which is above and one which is below. So in the parasol long axis, you look at the antroseptum over there. And this is the antroseptum and this is the infroseptum here. So the cut is across the antroseptum. So the parasol long axis is not just the interventricular septum, it is the anterior part of the septum. And the opposite wall is also called as a posterior wall or the infralateral. Both are the same and you can use it, no problems there. So you are going to identify the walls and look at the segments. There are only 4 segments here. You don't see the apex. So you have a mid and basal on either side. And lastly, you should look at the coronary artery supply. So the antroseptum is always going to be supplied by the LAD, while the posterior wall is usually by the circumflex, but it can also be with the PDA also, that is the RCA. So you can have a mix of both. Then next view is going to be almost similar, your 3-chamber view, where you see the apex a little better. So, but otherwise nothing changes here, except that you see the apex, the true apex here. While in the long axis, you don't see the true apex. So you never talk about the apex in the long axis. The other important view is the 4-chamber view. So the 4-chamber view, you can see that it is going to be cutting across a little lower down. So this is the inferior septum here. So what you see is the inferior part of the interventricular septum, and the opposite wall is the lateral wall. And here the segments are 3 plus 3. So you have 6 segments, which includes the apex also. And the supply here is going to be the septal perforators, and you can have the RCA supplying the lower part here, and then you have the circumflex predominantly here most of the times, and then you have sometimes you can have the LAD also mix of it. So always remember 3 parts of it: which wall, how many segments, and what artery supply to each of these walls and the segments. And the final view, apical view, is going to be the 2-chamber view. So the 2-chamber view is going to be again the inferior wall, and then you have the anterior wall here, and then you can see that the cut goes in a different direction, and then you have the segments here, 6 segments, and then you have the arterial supply. So it's going to be the diagonals here, and then the RCA on this side. So this is in summary the different walls as far as the apical views are concerned. So putting everything together, so you have the long axis, 4-chamber, 2-chamber, and then you have the 3-chamber, which is synonymous with the long axis. So look at the walls and look at the segments and the arterial supply, which is very commonly available in almost all echo textbooks and even beyond other books also. Now, a brief look at the short axis. So always do a sweep. Start from the basal segments. The basal segments always, most of the time, is unaffected, and they are the ones which contract very nicely. But once you go to the midsection, then you can have the vessels which are going to be affected. And then you have to make a look at, absolutely imperative that you take a look at the apex. You go a little beyond, and then you should look at the apex. Apex is something where you don't see the papillary muscles. So moment you see the apex like this, and then you don't see the papillary muscles, that means you're hitting the apex. And look at the contraction over there. And based on that, you decide whether which wall is going to be. So here you see only 4 walls. You have the infraseptal, the anterior, the inferior, and the lateral wall here. So you don't see the long axis, the parasol long axis segments here. Now, based on this, again, this is again a summary of how you should look at in terms of the vessel. So the LAD is always going to be the big fellow, which you're going to be very interested in, and with the ones which give you the most problems. And then you have the RCA, and then you have the circumflex. So this is the arterial distribution. And again, this new sort of way of approaching it. So the American Society of Echo has always been the synonymous with the 16 segments. You can still use it, no problem there. The American Heart Association came up with 17 segments because they wanted, whether it's a nuclear medicine or whether any other multimodality imaging, should have the same type of approach. So that's why they introduced this. But remember that in the echo, your apex is going to be a little bit of a problem. So usually this top portion of this is the muscular part is always going to be better seen when you put in contrast. Otherwise, it's very difficult. It's not going to move that much. So usually you'll end up doing the 16 segments, but the apex, if you see it, great. But most likely you'll be seeing it with contrast. So this is just sort of an insight into the 16 segment model and the 17 segment model here. Now, when you look at RWMA, what are the points that you should be looking at? So always look at how many segments are involved, the number of segments. And once you have decided on that, is it hyperkinetic? Is it akinetic, dyskinetic, or normokinetic? So you have these options over there. And look at whether it is the thickness is preserved or not. That means the full thickness when you compare it to the adjoining segments, is it the same? Or is it only partially thick when you compare it to the adjoining segments? Or is it really thinned out? And also in inferior wall MIs, always look at the RV free wall also, so to see whether there's an RV infarction. And you, based on this, you can have your own assumption. If you have a basal segment which is involved, you will say that you are more likely to deal with the proximal lesion, or if it's a mid and apical, you will say it is a distal lesion. Proximal lesions are always dangerous, and once you put in the basal segments that are involved, so that means you're telling the clinician that the lesion is going to be more higher up. So you can come to a conclusion based on whether it is a single vessel disease, double vessel disease, or triple vessel disease. So based on the wall motion. So many times you can have the triple vessel disease without wall motion, but that's a different area altogether, which I'll not touch upon. Now, what is this business of preserved thickness? You can see that if it's a very severe infarction, so that means from here to here, the entire muscle is gone. So this means that there's going to be thinning of the muscle, and this is not good. And if you say that it is going to be thinned out, that means most of it is going to the muscle is not there. Or you can have partial thickness also. So this is how you should look at thickness. And in terms of the kinesia, so normokinesia, hypokinesia, akinesia, dyskinesia. So those are the sort of pictures which tells you what type of wall motion abnormality it is going to be. Now, just a brief, few tips as to how you should get good images. So when you do something like this, always when you're looking at the LV wall motion abnormality, reduce the depth. Just focus on the LV. You don't have to see the RV or the right side or even the LA also. So the more you optimize the depth, the better your confidence in seeing the segments and then looking at the walls themselves. And always you're looking at the endocardial border definition. So this is always going to be a challenge because these are the longitudinal fibers which run parallel to the beam. They're not perpendicular, as Dr. Solam pointed out. The more perpendicular, better you see. So it's always going to be a problem. If required, increase the gain a little bit so that you get the definition very clearly about this. Now, next, foreshortening. Again, this was pointed out. So if you go one space below and you're not including the apex, so you have a very rounded, muscular, very briskly moving, very actively moving LV apex. That means it's not a true apex. And this is where what will happen is your apex is somewhere here. You're actually looking at only here and you're missing out on a pathology here. There may be a clot, there may be a wall motion here. So in that case, what you should do is you should try going one intercostal space lower down. In some patients, it is not possible, so be aware of it. But most of the times, the attempt should be made to go a little lower down, and you should see the shape of it. It's more triangular, more peaking, while this is more rounded. So this is a message as far as foreshortening is concerned. Next is when you're looking at the short axis, always go for a view which is going to be more circular. You've always been taught that the LV is like a cylinder and in a cone at the top. So your LV shape in short axis has to be as circular as possible. When you have it as circular, that means your segments are going to be proper. When you have something like this, which is more oval, that means you're not getting the walls and you might mistake this as an anterior wall, which might actually be the lateral wall here. So be very careful about it. For this, you sort of push the patient little more lateral and make it as lateral as possible. So what is called as a steep left lateral position where you bring the heart away from the sternum. So just a few tips. Look for myocardial thickening, and if required, you always acquire it and then slow down the sinus speed. So then you look at the thickening much better. And be careful of paradoxical IVS, which something like the LBBB post-cardiac surgery, you can mistake it for wall motion abnormalities. And it's very important that when you look at the wall motion, it has to be the guidelines tell you that it has to be two adjoining segments. So when you have two adjoining segments, they are more likely to be coronary disease. If it is just one segment, more likely to be due to other diseases. But the thumb rule is that you have to have two adjoining segments. And when you have an opposite wall, which is normal, and you have the other wall, which is abnormal, compare both the walls. So that will give you a better perspective. and always correlate with ECG. So if you have an ECG, always look at the ECG, ask for the ECG, very important. Ask for symptoms. Somebody who's giving angina symptoms, you know that the wall motion abnormality is sometimes very ambiguous. You can sort of be more confident. And look at a patient profile. So most often we see patients who are 25-year-olds who are doing very well, and suddenly somebody decides that they have a wall motion abnormality. It doesn't make sense at all. So just be little more careful. Somebody who's got diabetes, hypertension, more likely. But a young person with nothing doing extremely well, and you say wall motion abnormality, just be careful. So don't be too enthusiastic in diagnosing wall motion abnormalities. And most often we do see that you get carried away by the wall motion, and you might end up not seeing small defects like an ASD or a small one. So you have to be careful. Don't miss them also. And very important, if you have the capabilities, if you have the facilities, always save these images, especially good images, and which can be compared later. Wall motions can be dynamic sometimes, and we always need to have a good comparison. So always store these images with an ECG preferably, and that's how you should approach it. Now, a brief look at LV function. So LV function plays a key role as far as coronary disease is concerned. And always it is good to have the modified Simpson's and method, and especially the chamber, two chamber. So this is the recommended. Anytime there's wall motion, never do a single plane 4-chamber view. Always go for a 4-chamber, 2-chamber. So this is called the biplane, and this is how it should be. And we always have these shortcuts, how much ever we tell you. So, you always sort of go for the visual EF. But if you do go for the visual EF, be very careful. And whenever there's an apical infarction, the EF comes down. So the apex plays a big role in LV systolic function. So that means if the apex is abnormal akinetic, that means the EF is drastically going to come down. And then you have the interventricular septum. So many of literature publications say that the septum is the motor of the left ventricle. So anytime the left ventricle is going to be affected by the interventricular septum, even if a simple LVV can bring down the EF. So any infarction affecting the entire IVS, that means your visual EF, you have to be very careful. Preferably, I would suggest you go for a modified Simpson's. And when you look at visual EF, combine both short axis as well as apical views. Don't just go for a short axis views. This is a common mistake which you do, and look at as many apical views as possible. So that gives you a better perspective. And of course, you have these other additional imaging modalities. If you have them, use them. And remember that the EF generally is very significantly decreased in LAD lesions, anti-wall MI. So it significantly comes down, and not to that extent when you have a RCA or the LCX, or when you have a combined lesion, the LVF really comes down. And LVF comes down more with akinesia, and also if they have any pre-existing diseases. So these are small sort of correlations. You have to be very careful. And also when you have very high heart rate or very low heart rate, you have to relook at it and be very careful about it. So brief look at how it can be helpful, the speckle echo, but it has got very limited capability. So don't be entirely dependent on it. Though there are a lot of publications, it has its role, it has its utility, but it has some limitations. So be very careful. Sometimes it can mislead you also. And what about 3D EF? 3D role of 3D also. So here primarily the role of 3D would be to look mainly at the EF itself, and to some extent if you use the multi-slice, it can give you a better perspective as far as the wall motion is concerned, or if there's any thrombus, you can look at it. So it's got very limited role. Now, the other important, not all hospitals have it, but again, it's very difficult to have this. So if you have contrast, you use this contrast to look at the endocardial border definition, or for looking at any masses over there. So this is the other imaging modality which you can use. Now, tissue Doppler can be used, but be very careful. It has got its own. I've seen many people use tissue Doppler saying that tissue Doppler is low, the inferior wall is hyperkinetic when you are doubtful. So be very careful, because it can be sort of misleading also. It is a very regional sort of a parameter. So it has got very limited role, but can be used, but be very careful about it. Now, another important part of the coronary heart disease workup is the diastolic function itself. So when you have a patient who's got LV dysfunction, systolic dysfunction, somebody with a grade 1 is going to be better in terms of how the patient does. So grading of the diastolic dysfunction is also equally important when you're looking at the diastolic function. So this is a patient who came in just in a matter of few months, And you can see that patient had very sort of severe diastolic dysfunction, wasn't doing well. And this is something which you should sort of, if you document it, patient will, when they come back, you'll see that this patient continue to have a lot of heart failures, a lot of symptoms and repeated hospitalization. So the role of diastolic dysfunction is also very important. Grading is very important. You have to mention that. And also the E by E prime, you have when to do it, when not to do it. So that has got its own indications, contraindications when you cannot do it. But whenever it is possible, you should mention the LV filling pressure and the E by E prime. And also the PA pressure gives a lot of information. Now, let me go on to another area. So this is the complications of myocardial infarction. So we are going to look at the mechanical complications primarily. And papillary muscle rupture. So you have a patient who's there in the triage or in the CCU. Suddenly the patient has deteriorated and you've been called and you're asked to do an echo. So when you look at the MR, if you see the MR which is eccentric, so you're trying to find out why is that MR there? What is the mechanism of this MR? And always look at, especially in the acute coronary syndromes, look at the papillary muscle. If you look at the symmetry which has changed, so you have a very funny looking papillary muscle and which is moving abnormally. As you can see here, it is a partial rupture of the papillary muscle. Then you can immediately correlate and also look at the short axis. So that also gives you a view which papillary muscle is identified. So papillary muscle rupture, especially when you have symptomatic patients. So be very careful about it and look at it from all views. Next is the ventricular septal rupture. So this again, you'll see it quite frequently. So very important that your traditional views may not be able to pick up. So the clinician will be there, saying that I hear a murmur. So do the echo. I suspect a ventricular septal rupture, and you do your fourth chamber and you're not able to see it, especially the small ruptures. So go a little off axis. That means you tilt the fourth chamber and make it a little different in a different angle altogether. And that's when you pick up these ventricular septal ruptures better. So again, there will be a lot of thinning. Whenever you see a little bit of thinning, go close to it and then see whether you can pick up these defects. They can be single, they can be multiple. And is it apical? Is it an LAD or an RCA? So again, whether it's apical or basal, and also measure the size if it is possible. Look at the RV size and function. That plays a key role in the stability of the patients, and also mention the PASP. And of course, the LVM. And in the basal ventricular septal rupture, it's important to quantify the MR, because sometimes if the patient goes to surgery, does the MR need to be attended to by the surgeon? That has to be looked into. So looking at MR also. Now, LV female rupture is very devastating. So suddenly the patient starts to become very symptomatic. You're called to the CCU, and then moment you see pericardial effusion, start to suspect. Of course, there are other causes for pericardial effusion, but once the patient is symptomatic, unstable, hemodynamically unstable, and you see pericardial effusion, think possibly that there could be a free wall rupture, and it can be anywhere. Usually it's a lateral wall. You can see here it is the apex. So when you have a pericardial effusion, unstable patient, and when you see an area where there is a loss of continuity and thinning, so that means that more likely to be a free wall rupture. Sometimes these patients develop a thrombus and then that seals off, and then these patients survive a little better when they are sort of taken up for surgery. So they have a better outcome. Now, the other side of the free wall rupture is a pseudoaneurysm. So here again, there is a rupture. There is a loss of continuity. As you can see here, there's no muscle here at all. So there is an abrupt loss of muscle here. And then this is a tract. So this blood from here goes into the pericardium. And what the pericardium does is it seals off. It sort of, fortunately for the patient, it sort of forms a pouch here. And this is where the collection happens. And then when you see a very narrow neck, more likely to be a pseudoaneurysm, and you have to identify where it is. Is it in terms of location, which wall it is? And whenever you see a pseudoaneurysm, is there a thrombus? So look for a thrombus over there. And then a true aneurysm is different. So here you have a very broad-based neck here, and you can see it's a very large neck, and there's no loss of continuity here. It's just that the wall has thinned out and it's become more fibrosis. So you have, it can be anywhere again, usually at the apex, but it can affect the other walls also. It can be scarred, so mention if it is there, and also look for any thrombus here. And then look at in inferior wall mice. Always make it a point to look for the right ventricular function. So if you have a dilated RV, which is going to look like it even in the short axis, that means that there is going to be more likely to be an RVMI. And then, of course, there's going to be a little bit of TR, which will worsen over a period of time. And this is something which you have to make sure that you look at it as far as the inferior wall MIs are concerned. And pericardial effusion, a lot of other causes are there. So, but if you do see it, mention where you see it, and then in terms of how much it is, severity. And just a brief look at what is infarct extension. You have done an echo today, and then you see a wall motion, and tomorrow you see that the same area, LAD territory, anterior wall MI, suddenly it has become a little more segments are involved. So that means the infarct is extended. So additional segments are involved. Infarct extension is the same wall motion now suddenly looks different. No additional segments are involved, but it's the same segment. Now it looks a little different. So it has expanded a little bit. So this is called as infarct expansion. And these are the patients who are likely to go for a aneurysm or a pseudoaneurysm, or you can go for a rupture. And look at thrombus. So thrombus is very synonymous with coronary disease. And for this, you have to increase the gain a little bit. So you get to see the sec a little better. And especially when you see an akinetic area, that means your focus should be on whether there is a thrombus. So focus on the akinetic areas. And when you have an aneurysmal area, you're more likely to see it. So it's always a difficulty sometimes when you see this image, which is lower down, where it looks almost like a wall. So if you are in doubt, put a question mark, and you can always look for a contrast to help you if you have contrast facilities, but put a question mark at least. So that gives the clinician an idea that maybe there's a thrombus over there, and they can look for any additional signs later, or look for additional or go for additional imaging modalities. And thrombus comes in various shapes and sizes. So something which is very big, it's not easy to sort of, miss this. You'll definitely get it, and look at it from all views, off axis views, even short axis views. So try all views. And contrast, which I've already told you. So I'll just last few slides, a few points to note. So when you're mentioning in the report, as I told you, if you do see it, a wall motion, so make sure of the wall thickness. So as you can see here, the wall thickness is preserved. It's an akinetic area, the top image. But if you see the bottom image, it is really thinned out. So you should mention in your report that it is thinned out over there. If it is completely thinned out or partially thinned out. Next is scar tissue. A scar tissue is always going to be very bright, and it's going to be very sort of, as you can see here, the septum in both images. So when you see something like that, it's a scar tissue. So mention that is scarred over there, and in which wall. And also look at the LV shape, and these are follow-up patients. So when they come later, you'll suddenly see that the LV is becoming more, it's lost its shape, it's lost its cylindrical shape, it's looking more globular. So you have to mention the shape also, saying that it is more globular, and this is called as LV remodeling. And be aware, lateral walls, this is the most difficult one. On ECG, it's very difficult, symptoms very difficult, and even on echo, it is very difficult. So this is a very difficult area, the lateral wall, the lung shadow, as Dr. Shrikant pointed out. So you have to be careful that you don't miss a lateral wall. Go a little off axis and see if you can get it to avoid the lung shadow, or of course, ask the patient to hold in expiration. And same thing with the anterior wall. So you can have the lung shadow coming and obscuring the anterior wall. So these are the two walls which are always going to give you trouble. Inferior wall is often called as the graveyard of the wall motion abnormalities, because it comes very close to the liver, and then it sort of holds the inferior wall a little bit, and you will think that a little bit of delayed lag in the wall contraction thing makes you think that it is inferior wall. So be very careful. You're going to look at the thickening over there, slow down the speed, and then again try and correlate as much as possible. So post interventions, when you have your call, look at the LVEF. That's what the clinician is wanting to be looking at. And is there any new wall motion abnormality? Localize the territory, see the angio report, and see where they have done, which vessel they have done a plasty, and then try and correlate what's happening to that particular region. And if there has been an MR, any worsening on this. And of course, pericardial effusion is something which it's very sort of always high on the list as post PCI. So if there's even a little bit of pericardial effusion, immediately inform, and also look for any tamponade signs. And again, when in CABG patients, you're looking at post-surgical patients, look for clots. Those are the ones immediate post-surgery. Chamber compression can happen. And of course, looking at the PA pressure. So in follow-up, you're going to look at the true aneurysms, LV thrombus. You're going to look at wall. Has it over a period of time has started to thin, has become scarred? Any change in wall motion? Maybe it has improved, maybe it has worsened. And looking at the MR, has it worsened? Has it improved? LV size and shape, the EF, the diastolic dysfunction, RV size, and also looking at the TR severity. And then post interventions, you have these two. And make sure that just because there's wall motion, you don't miss other coexistent diseases, or it can be the other way also. Another disease can be dominant and you will not give too much of attention. So be careful when you have coexisting diseases. Just one look at ischemic MR. So again, in ischemic MR, you see that the usual culprit is the posterior, the inferior wall, especially the posterior wall. So where it pulls the posterior mitral leaflet downwards, and then the antemitral leaflet, as you can see, it is not going to coap properly. It is going to coap somewhere in the middle of the posterior mitral leaflet, and this causes the MR jet to go posterolaterally. So that is a clue that it is going to be an ischemic MR. And of course, I'll just a look at how you can look at coronary arteries. That's a different area altogether, but if you see it, great. But otherwise, you should always be a little inquisitive and try to get it. And then sometimes when they have done a very proximal stenting, you might end up seeing the stent which is coming out there. So you can have these unusual sightings. So always look for any unexpected things. And T's, that's when the clinician decides. It has got its own values in terms of when the MR mechanism is not made out. If the window is not poor, then we go for T. And to conclude, so just to summarize what all I've told, so when you do the imaging, is there wall motion abnormality? And if you do see it, how many segments? And based on that, you decide it is single vessel, double vessel, or multi-vessel. Where exactly is it? Is it distal or proximal? Is it hypo or akinetic or dyskinetic? Is it thin, preserved thickness, hard, or neurosmal dyskinesia? And looking at the LV, especially the akinetic segments, look for thrombus, look for sec, and is it organized or recent one? LV function, again, EF, try to be as objective as possible. Look at the LV size and severity of the diastolic dysfunction, ischemic MR, worsening, complications of MI, whether in the acute stage or in the later stage, and echo can be at casualty. So each area, wherever you do echo, has got its own value. So you should know in a different each setting, it is what is the finding which you're going to be looking at. And always compare old reports. It's a good idea to look at it. And if you have the facility, look at the other additional imaging modalities. So these are the ones. So mechanical complications, LV function, and RWMA. And so as I said, in triage, it's a different approach altogether. In a CC, it's a different approach. And then in interventions, follow-up. So each sort of setting has got its own sort of checklist, and you have to be aware of all these other things. And you can use these different types of echoes, whether it's conventional or even up to the handheld echo. So thank you for your kind attention.
Is there any questions? That's extensive coverage. It will cover for all your exam, even for future. And any question for Dr. Srikanth Sola? We didn't have much time because very basics of ultrasound, nobody like to discuss. Especially I don't like to discuss. So if you have any questions, please ask Dr. Srikanth Sola. Thank you, sir.